Bismillah ar-Rahman ar-Rahim, my dear vascular colleague. Another lecture on peripheral vascular duplex scan. My name is Dr. Muhammad Omar Farouk. I'm a consultant vascular surgeon. My learning objective of this lecture is to give some tips and tricks about arterial duplex scan and how to reach a correct duplex diagnosis. It's very important after having duplex course to have a practical application of it. And I always like to mention that very important to have a clinical scenario that you need to gather from history and a quick examination. So clinical scenario is very, very important. And you do a quick history and a very quick examination. Concentrate on the important part of the information. And there is no single element, no single history or examination will give you the full story. And always have multiple differential diagnosis. Open your differential diagnosis to include a lot more and then try to get what is the correct diagnosis. This is the case, patient presented after recent cardiac catheterization. This is important information. Recent with a vascular access, they went from the right femoral artery, and they mentioned that it was difficult procedure, not easy. 1 day after the catheterization, a bruit was detected in the patient right groin. An ultrasound study was performed. So this is the history. This is a color Doppler. When you put the color Doppler, you see this amount of color, which is not very clear, is not well delineated, and you can feel a bluey under the hand when you do the duplex scan. And let us say that you put a spectral Doppler in that area, and you hear this systolic phase with diastolic filling in between the phases. So this is the signal that you get from the area of the common femoral artery. Now, spectral Doppler below the vascular axis, if you go to superficial femoral artery below the lesion, you see this spike of wave and no diastolic filling at all. So this is the spectral wave that you've been able to see below the lesion. What is your differential diagnosis? Number one, arteriovenous fistula, traumatic from difficult catheterization, or it can be arterial stenosis, or it's a pseudoaneurysm, which you're unable to delineate, or there is an arterial dissection. So these are the four duplex diagnoses that you can have. If you get a little bit of better picture, you can see this is the filling of the artery. You can see the common femoral vein is enlarged with a very high velocity blood through. And some of the images, this is a fantastic image that you can see a certain point where the artery and the vein are nearly touching each other. So these two pictures are just adding to your information. Now, the correct diagnosis is arteriovenous fistula post-traumatic after cardiac catheterization. And as we have seen, or little bit of tips about the discussion, the color Doppler image will often demonstrate a color bruit artifact. This is shown in the first image. And the previous arterial catheterization, sometimes you get a little bit of hematoma. The image or color Doppler image of the region using a high PRF. Sometimes you need to increase the scale of your PRF in order to see more of the tissues, but it is difficult. Usually it is painful, you're unable. If the patient have dressing on the wound, you can change the dressing, put an opsite, and then you can put gel over the opsite, and then you can do the duplex scan. Because this is important in the patient management. And also, if we discuss this case, the arteriovenous fistula can happen maybe less than 1% and can result in puncture of the artery and the vein, and there will be a direct communication between the artery and vein, and it is extremely difficult to delineate this communication area. There is a significant pressure gradient will result in the focal area, and there will be increased velocity. So the blood will have increased velocity in the common femoral vein because the flow is going from the artery to the vein in very rapid way. So you get the common femoral vein distended, while the distal superficial femoral artery, you get the spectral signal that we have seen, which is weak and only systolic phase and does not have a diastolic filling. If you put your probe over the common femoral vein, you see arterial contamination of signal to the venous common femoral vein. So these are important information. Always use three things as we have mentioned. We mentioned that you need to have the B mode image, and you must have the color, and you must have the spectral Doppler. And when you get these three elements, then you can have information about these tissues. Not a single one of them will give you the information. So you need to gather all these three elements. A spectral Doppler, as we have seen, in the arteriovenous fistula is very spectacular because you get the Doppler signal in the artery and the vein, and they have a special character. You get a diastolic phase in the arterial signal, so it comes like this. So diastole is filling, while distally to the common femoral artery gets, which is quick upsurge, and you don't get diastolic filling. In the venous wave, you got a loss of respiratory variation. So I hope that the take-home message from this case is arterial venous picture is not very clear due to the tissue vibration under you, but tissue vibration give you a clue what it is. A high PRF will eliminate the bruit and localize the size of fistula, but it is sometimes difficult. Arterial proximal to the AV fistula will have a diastolic filling phase, while distal to the fistula will not have a diastolic filling. And the waveform of the artery and the vein obviously is very much different and will give you a clue about the diagnosis. And I hope this case give you a quick scenario. These are the references if you want to read about the carotid duplex. And I wish you all the best and thank you very much.